Dr. Sherri Treasurywala. She is not new to UCI. She's been at the Paul Merage School of Business for some time, teaching in the Executive Healthcare MBA program. She herself has an MBA from Cornell, but also that's after getting a PhD in gene therapies for brain cancer. In terms of global health, she's been with a very well-known consulting firm, McKinsey & Company, for several years, working pretty much all over the world, looking at, especially in Africa, looking at implementation of health programs. And she also worked as Director of Global Business Development for Hoffman LaRoche, another big multinational corporation. I see somebody looking for us. Yeah, this is it. It's an unusual place for a seminar. So she's come to us today to talk to us about her work and interest in public-private partnerships in healthcare. Social experiments are always implying something. People think of them as, oh, you're doing experiments on people, but I think she means it in a different context, and this is to integrate ethics and profits as well. So thank you.
Thank you for having me.
I don't think you need a point.
No, I'm good, thank you. I'm used to teaching very big classes, so this is a nice change. So I'm going to start out by telling you a story. In the late 1990s, once upon a time, there was a drug called Prilosec. And Prilosec was one of the first blockbuster drugs. And a blockbuster drug is a drug that sells over $1 billion in sales a year. And Prilosec was one of the first. AstraZeneca was the company that made Prilosec. And Prilosec is generally for acid reflux. So it's generally when people eat too much pizza, or when people eat too much fatty food, or if they don't have exercise routines in their lives. For the most part, they need things like Prilosec, which reduce the acid in your stomach. So it's a lifestyle drug, if you will. This drug was going off patent in a year. It brought in yearly $4 billion. $4 billion every year for the company. And as I'll talk about later, patents expire after a certain amount of time, and the patent was expiring, and the company wasn't too happy about that. The reason is that when a patent expires, the midnight that a patent expires, there are laws in place that the next morning there are generic or quote-unquote copycat versions of that drug in the pharmacy. They are usually about 68 to 80% cheaper.
Ready
so you can imagine, yes. So you can imagine the next day, from 4 billion, you're going from 4 billion to probably, some, high hundreds of thousands, and that's not good. And the company was very worried about it. So they assembled this team of people, and there were business people, there were people from corporate, there were people, consultants, there were chemists, there were lawyers, there was a big group of people, and the meeting was basically to say, how do we save this $4 billion a year? I mean, we cannot afford to lose this. So let me tell you just a quick tidbit about Prilosec. Prilosec is made up of 2 parts, like most drugs are. They're isomers, which means they're actually mirror images of each other. And most drugs are like this because they provide some kind of stability. When you ingest a drug, you want there to be some kind of stability. You want the pill to stay round and not disintegrate, etc. So the way Prilosec worked was, let's just say that it had 2 parts. And this is the only part that actually worked in your body. This is the only part that actually went in and controlled the acid in your tummy. This one was just excreted. So it kind of went along, but it actually did nothing. So this team of people that was assembled there, they had this idea, and they said, well, what about if we make a new drug, and that's this.
The active ingredient.
Yes, and they, in a matter of months, which is really remarkable, they were able to pull together enough data to bring to the FDA and submit applications to the patent office, etc., and they actually patented a new drug, which many of you might know as the purple pill Nexium. This is Nexium. This is Prilosec. This doesn't have any bearing whatsoever, and this is what gets, this is Nexium. Now, you might say, okay, that's just, that's very fortuitous. Imagine if initially someone had refined this molecule enough, there was just this, but they didn't. So, they came up with this idea, and that was fine. Now, here's the clincher. This drug, now Nexium, today sells over $7 billion a year. So, you would agree that people are buying it, right? I mean, $7 billion a year is not chump change. People are buying it. But here's the irony. This drug, Prilosec, still exists over the counter. You can go to Target and pick it up. It costs about $30 for a month supply. You can get a generic version. Remember I said once it goes generic, you can get a generic version of the same chemical for about $5 to $10 depending on your pharmacy plan. Nexium costs $120 a month. It's the same thing. Yeah?
Probably more expensive to make because of the red of the
yes, because of the distilling. So you have to get rid of this. But if you're making 6.9, sorry, I shouldn't mistake that. $6.9 billion a year. What's a little chemistry? It is. Now the way that the FDA reviews drugs is they actually require that when you propose a new drug, which is what they did, it has to be somehow superior to the old drug. And that just doesn't have to be in efficacy, that doesn't just have to be in how it works, that can also be in safety, that can be in how many times you take the drug, how you take the drug, it's a pill, it's an IV, etc. Nexium was better than Prilosec. So in 100 people, based on a fuzzy logic, it worked better on 2.6 people out of 100 people than Nexium. So statistically, if you take a statistic, I hope there are no statisticians here, but I'm a big believer that statistics are, you can be very creative, and they obviously were because they convinced the FDA to give them a new drug, to go on. Now again, now that has a patent protection and that goes on and people are buying it when they could be buying the same thing for $30 or even less for $5 to $10. So I want to start out there and start my story there. I'm going to start out by telling you about a little bit more about pharmaceutical companies, why the way that they do business is pretty much coming to an end. There are many reasons, and I'll go into it. The Blockbuster, as I talked about, products that make over $1 billion, for many reasons, it's gone. So the pharma companies, who serve health. I mean, these people make drugs, or if you talk about medical devices, they make medical devices, or biotech companies, they make drugs that are supposed to be in the best interest of health. So we're going to talk about whose health and whose best interest and how we can kind of come to some kind of consensus of, all this money that they make versus all the people that in the next part we'll talk about who suffer from diseases that are preventable, they're curable, they're treatable, and yet these diseases exist and affect millions and millions of people, and they continue to do so. Right, so while we're out, while AstraZeneca is out creating, another drug because someone eats too much pizza, there are people who are actually dying of diseases that can be prevented. I mean, there's, in today's world, when we're talking about, technology, mobile technology, and internet, and all these kind of new applications, it's really a shame that there are people who don't have access to, basic health, and it's a vicious circle. You don't have health, you can't go to work. If you can't go to work, you cannot afford health. It's kind of a cyclic thing, it just keeps going around. And then I'm going to end with some examples of public-private partnerships. Having worked through one myself, I'm just going to explain, my role in it and give you some lessons learned from my experience. So I want to start out by just talking a little bit more about drugs. Companies have, if you were a drug company, you might as well go to Vegas, because you have better chances of winning in Vegas than you do of developing a new drug. So you start out in drug discovery, and this is the basic research part. Ironically, this is funded mostly by us, taxpayers, because it happens at the NIH, it happens in academia, it happens in places that are funded by usually NIH grants and funded eventually by taxpayers. Everybody goes to the same meetings. They go to AACR, they go to ASCO, they go to meetings that people pretty much, hi Terry.
Hi Sherri.
That pretty much everybody in this industry attends, and every time there's a hot topic of a new receptor or a new molecule or a new cell or or a new cell marker or something like that, and everybody is jumping on the bandwagon. And so you start out with these compounds. And so the way I liken it is I like to do a lot of analogies. The way I liken it is these are all, you have a lock, and your lock is the target. So in a disease, let's just say it's diabetes, what is your target? It's insulin, right? It is the functioning of insulin. So that is your target. And then you have these compounds, or what you call leads, which are also the keys. You don't exactly know which key is going to fit into that lock because you have to make that, but you have to keep trying. And that's what these compounds are. And you have to start out with thousands of keys hoping that one of them fits into that lock. You then go on, you test in animals, you test in human beings, you submit FDA approval, you scale up, and then you get an FDA approved drug. Now I'm making this much more simple than it really is because number one, there's huge attrition. You start out with 5,000 to 10,000 and things fall out for many reasons. They could fall out because they're toxic, they could fall out because there's no market potential, they could fall out because they're very difficult to make, they could fall out because they kill animals, and then that's the death of them because you don't want that to kind of go on into humans. And this is very optimistic. It doesn't always happen. So it's a very different industry than a chair. You start out to make a chair, you say, okay, I need legs, I need wheels, I need a seat, I need material, and at the end I'm going to have a chair. When you start out here, you really don't know what you're going to end up with here. You may end up with absolutely nothing. But you still have to pay for all this. Someone still has to pay for all these things that didn't work out, all the things that went into attrition, that someone still has to pay for this. So when people talk about the cost of drug development, $1.3 billion per drug, that's not really true. It's not per drug, because it's if in 10 years a company has 2 drugs come out, they've probably gone through thousands of these leads that have gone through and fallen out at different stages, but that cost has to be absorbed. So in essence, it's expensive. It's an expensive process because it's an unknown. It's not a straightforward linear, input, manufacture, output, and you're done. It's very uncertain. It's full of attrition, and most of the time it really doesn't come out to this happy ending. However, when I started out, I said that everybody's chasing these. Everybody's chasing the same research. Everybody goes to the same meetings, and if that happens, then everybody's pretty much on a parallel course, focusing on the same hot topic against the same disease. And so, as a measure to that, we have patents. So companies patent their leads or their compounds at this stage, basically to block competition. Now there are many ethical issues about, should something like this be patented, and we can discuss that later. But I just wanted to point out that you are patent protected here, and your patent only runs for a certain period of time. It's 20 years, give or take. Now, if you patent here, and what I didn't mention is this process takes about 9 to 10 years. Does anybody remember what they were doing on June 7th, 2001? Because you have to. Because if you were here, you would have to remember. I mean, that is how long it takes. I mean, that is the process. It's not a day, it's not a week, it's years. And even then, it's not a guarantee. But if it takes that long, and if you file for a patent here, if your patent is 20 years, which a patent basically gives you exclusive rights to market that drug. If your patent is 20 years, you've just lost 10 years right here. So you have another 10, which is the exact debate that the pharma companies will have with you and say that's why our drugs are so expensive, because then we only have 10 years of patent life left to recoup all of the investment that we made, not only in this drug, but in all the drugs that actually, not drugs, but the leads that actually fell out in the chain. That is the reasoning. And that is also the reasoning why drug companies will tell you that it is cost inefficient for us to develop drugs for diseases like malaria and TB and what I call the poverty diseases, unfortunately, because at the end of this, even if they do get the approval, they're never going to make enough money to recoup the investments that they have put in. Because remember, it's not just for that one drug, they have to take into account all of the other things that they have to pay for, regardless of whether they actually come to fruition. So, in a nutshell, it's long, it's expensive, it's uncertain, and in doing this, you have to have a decent payoff. What's happening now is that companies are actually spending more money on research, and the number of approved drugs, which are new molecular entities, NMEs, which are shown by the line graph, are actually decreasing. So it's a dichotomy. So you're spending more, but your output is less. And you know, as I said, research spending is just skyrocketing. The other reason that pharma companies need to change the way that they, you know, do health now is because, remember I said the blockbuster drugs? The majority of blockbusters, 6 out of the 10 blockbuster drugs that exist today are losing patent this year or next. 6. Those are drugs like Lipitor, 7 billion, Plavix. You know, these are the household names, you know, unfortunately, that we have in the West of, you know, cholesterol-lowering drugs and, you know, blood, cardiovascular drugs, and they're losing patent. Now, you can imagine, you know, 7 billion loss, boom, because a generic comes in. I mean, we can go into stories of how people play games about that as well, but that's definitely affecting, you know, the diseases that pharma companies target, the way they're thinking now.
But don't those manufacturers of the blockbuster drugs also have a plan to either make their own generic, right? I mean, they don't essentially just drop out of the competition with the generics. What is how do they try to keep their corner of the market?
So generics compete on one thing, and that is price.
Right.
So when you come to price, there is really no competition, especially in the United States when we have insurance companies and third-party payers. You know, a lot of things go on price. There still remains a market for these what are called branded, you know, previously patented drugs, but they are a small market. They are a group of people who basically have the means and have the attitude that generics are not as good.
Yeah, so they go bashing generics.
The other place that markets come into effect is overseas. So in countries where, you know, when you buy a generic that is locally made, you're not quite sure if it's exactly, you know, if what you see is what you get. While you do trust something that has the brand Pfizer on it. So you're willing to pay a little bit more because it gives you peace of mind that what you're taking is really the authentic thing. And remember that markets that we're talking about, India, China, Brazil, you know, the BRICE countries, they are the ones who are up and coming. So there does exist a market, but you're still looking at about a 90% reduction in your sales. Because 7 billion, 90% is tremendous. And I wanted to share this with you because I just always think it's amazing. So we spend a lot of money on research. We have a lot of drugs that come out, and here's public perception, which has recently started to come out, which taints pharmaceutical companies. Is, by the way, the drugs don't work. If you look at this is a quantitative measure. It's called NNT, and if we start out right from the top. Antibiotics, which are used to eradicate ulcers. If you have H. pylori in your stomach, you can use an antibiotic cocktail, and it eradicates. It basically cures 10 out of 11 people. So the way you get this is 11 over 10, which is a ratio of 1.1. Yeah, these are cheap, non-branded generic. I mean, these have been around forever. Now you go down, and we'll, you know, you talk about something that we will talk about a little bit later. Lipitor, Avandia, etc. Many of these are actually pulled from the market now. 500 plus. That means that 499 people take them without any effect, but they're paying all that money for it. They don't work. Not good news for the drug company, because the more that these kinds of things come out into the media and into public perception, it doesn't behoove their bottom line. Drug companies make most of their money, spend most of their money on research and development? No, not by far. Research and development is about 10 to 11%. The majority of their money is spent on marketing and administration. We're never very clear on what that actually means, but we can be very sure that that means advertising on TV, in newspapers and magazines, and basically, you know, giving out pens, which I carry around in my, like, you know, voluminously in my purse. My kids just love it. It's like, what pen did you bring for me this time? And so this is where the money goes, and I think this is the angst of, you know, we've now talked about the fact that drugs are expensive. It does take a long time. And profit-wise, you know, that's like 3 or 4 times the return that GM had. You know, it's huge profit, which is good because that's how companies get the money. It's a cyclical thing. If you if you make money, you get more money, because that's what, you know, Wall Street sees. So, oh, you know, this company made a profit, and hence, you know, buy, and you buy, and that's how people make, and that's how they make more money. But I think this is kind of the you know, the hair that breaks the camel's back. Is 31% in marketing, and this year total ad spending, just ad spending this year, is supposed to be about $8.2 billion. Now, if you think of how many, you know, medicated mosquito nets $8.2 million could buy, that's a huge amount of money. But again, a business is a business, and this is a business. But we're going to talk about how that kind of changes a little bit later on. I just also wanted to share with you one thing. What is this? Anybody eat this for breakfast?
Before.
Okay. Do you know what grape nuts are?
I used to think they were real grape nuts, but they're not.
They're
Someone
not.
told me.
They're not. They're not. And the reason I put this up is because I want to illustrate something to you. I'll take this and the next thing I'm going to show you. A grape nut is basically a, oh, by the way, does it say whole grain? Yeah, just whole grain. Whole grain, ground up, deep fried, grape nut. Still a whole grain, deep fried. So when that came out, I don't know when you heard about it, but the Wall Street Journal did this article on it. And
I like grape nuts.
They're delicious, especially with all the vitamins sprayed onto them, Terry. No. But the perception. So I use this example because I want to point out to you the perception that people have of health and other things. And cereal, right? I mean, when this came out in the Wall Street Journal, there was a big uproar. You know, Post, you know, suffered a big loss. You know, there was this big, you know, people thought they were eating healthy, something healthy, you know, whole grain, you know, who knew it was fried with, you know, sprayed on vitamins. And it was an uproar, the stock prices fell, blah, blah, you know, it was just, it created this big thing, and now they've changed the packaging, and now they've changed kind of some kind of production mechanism of frying it in some kind of different oil. And then there was this. This is Dr. Robert Yarvik. He invented the artificial heart, and here he is in very stoic dress, very professional looking, and he's telling you that he is a Lipitor user. I don't know if you can see that, and he really see the number 36%. It's again statistically made up. It really doesn't. It really, if you actually look at it, if you look at this tiny print, which is not unintended, that it is gray on the bottom in fine print, it will tell you that it actually just, it helps one person out of every 100. Lipitor sells 7 billion a year. I mean, you can do the math of how many people it actually helps versus people who take it every day, suffer the side effects and have no effect on their actual health status. Nothing happened. When people are outraged about this, Pfizer stock didn't go up. I mean, didn't go down. No one was outraged. You know, the FTC actually. You'll never see this ad again, by the way, because it's considered deceptive. And by the way, Lipitor user, he took it once. No, I'm serious. He took it once for purposes of this ad, but then there were other ads where they showed a body double doing some rowing exercises, and that was considered deceptive. So you'll never see this again. But nothing happened. So, you know, it tells you that as a population, we care more about the fact that we're misled about our cereal. But here we are, you know, paying billions of dollars for a drug that comes with, you know, some terrible side effects, and, you know, nothing happens. There are reasons to think outside the box, and these are the reasons. Given all the things that I've told you about the drugs not being as effective as they claim to be, the drugs do have side effects. The FDA is increasingly scrutinizing what kinds of drugs they actually allow out in the market. There are public relations issues, just like the one I talked about. Is, you know, people are more and more saying, you know, does this drug really work? What are the side effects? Do I really need to take this drug? Is it because you're paying my physician, you know, to go to Hawaii next week that I'm getting these drugs, or is it because they're really going to work for me? So people are generally becoming more alert and asking these questions. Then there's the blockbuster patent, which is going to, you know, drain the industry of billions of dollars. And there are gaps in the pipeline, which we haven't talked about. But that basically means that, you know, even if these blockbusters are expiring, that will be fine if there were more coming out behind. But unfortunately, there are just gaps. So at various stages in the pipeline, in the drug pipeline, there are gaps. So there's nothing ready to come out to take its place. And it's kind of like being in a university, right? I mean, if you start a university and you have a freshman class, they kind of go on and become sophomores, juniors, and seniors. Now, if in 1 year you don't have any freshmen, that's going to affect you for 4 years, right? Because you can't bring a class and put it into the sophomore play, it's going to affect you until that that gap is filled over time. Yes.
Has anyone investigated the number of drugs that have come out by trends in biotechnology? Like, for instance, there was a big theme in signal transduction, I think back in the 70s. In the 90s, it's been more genomics. And I actually worked for a biotech company down in San Diego, and nothing was made of it like most of the startup companies. But I was just curious if anybody sort of looked at that, because we get these big trends in molecular biology, and a lot of them just don't pan out. And I think genomics hasn't been coming to fruition.
Yeah, I agree. I mean, I think genomics has been disappointing, but I also think it's because there was so much hype about it. That there, at some point in the last decade, I think people just thought that personalized medicine was like imminent. Like if you as a person had a certain disease, you would get a drug that would treat you individually for that certain disease, and it hasn't happened. I think because the focus is on the big diseases, so let's take cancer for example. Now there is no one kind of cancer, so there can be no one kind of medicine. And so even saying that, having personalized medicine for cancer, that's every individual, and it's cost ineffective to do that. Does that make sense? So there are two ways that you can use these technologies, like signal transduction or integrins or extracellular matrix proteins or however, whatever basis you have for your drug development. You can say that if this disease affects a lot of people, then I will make a lot of money because the population is big, right? If this disease affects very few people, then I have to charge a lot of money because I can only sell it to a very few number of people. And I think many of the genomics technologies fall into the second bucket, which is why you have Herceptin from Genentech. Or you have MabThera, or you have very specialized monoclonal antibodies or gene therapies, but you have to get tested. And if you're not a candidate for that test, you don't get that drug, which is exactly the way it should be, but that kind of cuts into the. Does that make sense? No. So then you kind of go back as a company and you say business is business, money is money. So let's go back into what fits, the masses. And then you kind of go back into that. But I think the biotech companies, are the ones who are going to be pioneering that element. Unfortunately, I'm sure you know that a biotech company is yet to make a profit.
Yeah.
Technically, there's market caps are high, and they're excessively, Genentech and Amgen, but none of them have actually made spectacular amounts of money. Yeah. We're still waiting.
But isn't it that when they go out of business, they usually start because they have somebody who discovered something in the lab and they try to go public. But if they don't succeed, they're bought by another firm.
Yeah, that's exactly the way they're set up.
By larger.
Yes.
And so they can either squash the idea.
So there's a few that are walking out.
Yes,
right.
Yes, absolutely.
Having made a lot of money.
Yeah, absolutely, yeah. And that's one of the ways that actually pharma companies are filling these gaps in the pipelines. They're saying, San Diego is actually very rich in biotech companies. People in garages are starting, like these little biotech companies, and with really good promise, but not a lot of money. And so, taking it through these trials and to get FDA approval is very expensive. It's $1.3 billion, and so you don't, generally people in garages, are pretty strapped for cash. And so they do, sell to companies. And actually, that's one of the big elements, what we just discussed, is why, the focus on global health, being a responsible citizen is actually important, because if you're a company that has very interesting technology, and if you're being courted by 20 different companies, you actually have a chance to kind of pick the right partner. And every company wants to be the partner of choice. And one of the ways that they are is because they say that they are corporate, they have social responsibilities. They're a good company to partner with. But we'll get into that. So these new avenues, and I'm now going to focus on the global health perspective. Orphan Drug. The Orphan Drug Act was enacted in 1983, and it was basically a way to foster research and development of new drugs for diseases that affect very few people. So in the US, the threshold is about 200,000. If a disease affects less than 200,000 people, then it's designated an orphan status, and if you develop a drug for it, you can designate that an orphan drug. And so that also holds true for diseases that are in other countries where you don't have big populations, but they are very real diseases and you need treatments for them. So this was meant to foster kind of the good part of drugs, the good part of healthcare. So I always say be careful of where your data comes from. This comes from the FDA, and it says orphan drugs approvals have increased significantly. Yes. I'd like you to read the fine print on the note. It says all medicines approved for rare diseases include first-line approvals and subsequent approvals for new disease areas. There is a loophole. It's called off-label use, which means that when you go through this FDA approval, so basically when you have an orphan drug, you go through and you get approval for an orphan disease. Say, okay, this drug it works for this orphan disease and only affects less than 200,000 people. But in the back of your mind, you know that it's going to affect 1 billion more people in another subsection of medicine. It's it's called salami slicing. We'll go through that next slide. And you actually say you're doing this for benefits, which I'll describe, but it's actually going to affect a lot more people and a lot more diseases than you're actually playing into.
Sorry, what's the benefit of presenting the drug as
orphan?
Yeah.
Right here. So no, that's fine. So you get 7 years of market exclusivity. So regardless of when you finish or when you stop, that 10, said 20 years on patent, etc. You get 7 years of marketing exclusivity. So for 7 years, you will be the only people who will make that drug. You get a tax credit, which is 50% tax of the amount that you spend on R&D for that drug. You get a 50% tax credit, which is huge. And exemption from fees. So you have to pay the FDA to review your application, and it's usually close to about $900,000. So that's a good chunk of change, depending on, of course, the complexity. But you're exempt from fees. You can also ask for other exemptions. Like you can say, well, since this disease only affects 19,000 people, my clinical trials will be very small, and hence you don't have to enroll as many people. You don't have to do as many logistical things. You don't spend as much money. So there are pluses to foster innovation, which is why these were put in place. But what's happened is that competition has come in, and basically what companies are doing is they're finding a way to find a orphan disease with which that they can get approval. Because I don't know if you know this, but as soon as a drug gets approval in the United States, you can sell it, you can prescribe it for any other indication. It's off-label use. So Botox, you all heard of Botox? Botox was never designed for wrinkles. Botox was never approved for wrinkles. Botox was approved for something totally different. And as off-label use, which is now the biggest use, it is a billion-dollar industry. So you get approval for the quickest, cheapest, most sure thing that you can get because you know that you can sell it for pretty much anything after. And that's what companies do. They salami slice. They say, okay, well, this is an orphan disease. I can pretty much, fit my drug into this and get approval. Once I get approval, I'm going to hit unexpected large markets. EPO, made by Amgen, biotech drug. It was originally intended to increase people who suffer from renal disease, kidney failure, also have a great depletion of red blood cells in their body. And Amgen, many years ago, came out with this drug called EPO, and it was an orphan drug. It was an orphan drug. They had estimated, very small numbers of people, and today it is one of the top-selling drugs because people who have chemotherapy because of cancer treatment also suffer from the same disease, and today it's a billion-dollar drug, which actually started out as an orphan drug and got all of this. So more and more, and again, you have the monopoly pricing because you're the only one for 7 years. And this was originally intended for a fair balance, to actually encourage pharma companies to make drugs for these diseases that are not commercially viable. But it's kind of backfired because of, the way that it's gone. And so, again, I just wanted to demonstrate to you the other side of what the FDA would say. The orphan drug status has been hugely successful. I mean, look at the upward trend of this graph. But I'd like to point out to you that the diseased populations that have been served have been very small. Things that you find in fine print. So going on, I wanted to now talk about the diseases of poverty. When you talk about diseases of poverty, they're actually based on 4 different dimensions. One is based on the social pattern. So where what kind of life you live, what you have access to, how educated you are, how old your population is, what kind of gender differences exist in them. The next is economic patterns, and this perhaps people would say is very crucial, is basically how much money do you have to afford health. And again, this can go into just not health when you get a disease, but even prevention, even things like malnutrition, and access to drugs, physicians, pharmacists, things like that. Dwelling patterns. This is becoming more and more of an issue because I think the last time I read the statistics, it's like half of the world's population now lives in urban cities versus before when it was actually skewed very much towards rural areas. Urban cities gives rise to pollution, overcrowding, squatting, slum dwelling, etc. And so this is a huge effect on public health because sanitation issues are, the air you breathe in, the kind of water that you have access to, it's a huge impact, and health policy. It's probably some of the most neglect, when the government thinks of, the funds that it allocates, this is probably one of the most ignored ones. But it's really kind of what primary care health programs you have, vaccinations, and for malaria, bed nets, really addressing the issues that arise because of these patterns. And here are just some statistics that are kind of shocking. Again, I want you to think about what we just talked about. We said that a company makes $7 billion a year selling a drug that is not even a new drug because people have indigestion. And now we're talking about these diseases like TB and infectious diseases, malaria, children, and all of these things happen not because there's no medical treatment or there's no intervention possible, but because it's just not affordable. And that is kind of the shameful part of this whole equation. Is the rich have diseases that are rich, which are very well understood and very well medicated, if you will, excessively medicated, if you will, because some of the medications don't even work, but people still take them. And then there are these diseases that are simple, biologically understood diseases for which there are treatment protocols. Actually, I should not say that because there are some of these diseases actually have drugs that don't work anymore because the diseases have now developed resistant strains to them. So it's kind of a sad situation, but it's true. And again, same thing. You look at low-income countries, and you see that the kinds of diseases that affect these people are different natures. You have infectious diseases. I mean, the antibiotics. That's not a cutting-edge, leading, technology-based thing. It's just antibiotics, and yet people die because of these lack of antibiotics. And if you look at the high-income countries, you see coronary heart disease, again, lifestyle issues, exercise, diet, and you see stroke, cancer, etc. But you see the disparity between the kinds of diseases that make companies rich and the kinds of diseases that are left to the wayside because they just are not economically viable.
Yes. But this is very telling that the second one in the low-income countries, it is coronary heart disease,
yes.
because we know that, like in places like India now, that's now, I think,
yes.
now the leading cause of death. And
yeah.
so it's likely that things like stroke and other chronic diseases will follow. So that's changing the pattern completely.
I completely agree. Although I think that I should say that there is a middle-income country level, which I think will first
might be like India. Or
yes, which will first see the effect of that because I'm sure where you're going is with the globalization of McDonald's and all this things that people are now eating similar to what we eat in the U.S. Again, lifestyle choices that people are making. But I think I would venture a guess that would first kind of go up, to the middle income countries, and then translate up into here. So just a hypothesis. What would be the motivation for a pharmaceutical company, again, remember, you're about to lose all of this money that you made on Blockbusters, you don't have many things coming out in your pipeline, it's, it's not a good situation to be in. So there are 3 things that motivate most people: money, recognition or being a star, and kind of keeping your house in order. So I try to fit those. And so here's the reason that pharmaceutical companies aid or are now becoming more aggressive in the global health I don't want to say initiative, but in the global health arena. First, it is money reasons, and the purple ones are money. It's cheaper to donate drugs than to dispose of them. Just give them away. Now, at one time, Eli Lilly donated, I think, ARV drugs, not ARV drugs, I'm drawing a blank, but either anti-infectives or drugs to sub-Saharan Africa. And they found that they were unusable. Why? Because they'd expired. But instead of just dumping them here, what they did was they sent them over there. Now their premise was that, well, we sent them 3 months ago, and yes, they were about to expire, but it's because of your logistical issues that they didn't get to you in time, and hence it's really not dumping. It's just that your frameworks, your logistics were inefficient.
In fact, I think GSK just did that yesterday.
Maybe it was, well, yeah.
They did one in Malaria, so they marketed for 5%.
Okay.
The normal price.
Okay. But I think that's more of the third part. So this is more the dumping of knowing that something is expiring, knowing that you're not going to be able to use it. When you have something that goes off patent, suddenly you may have more of a decrease than you anticipated. You have all this thing in your warehouse, you want to get rid of it. By the way, do you know that if you were a professional thief and if you wanted to steal something really valuable, you should not go into a jewelry store, you should rob a warehouse of drugs. Serious. Like, people rob warehouses. Like, people make holes, like the Ocean 11 movie, like where they make a hole in the ceiling and they drop it. People do that. Like they rent trailer trucks and they rob medicine. And
is it for shipment to other countries or for sale here?
Mostly for sale here.
Yeah. Online maybe?
Online, in swap meets. I mean, it's amazing in how many ways people can access it. It actually becomes a big nightmare for companies, because then it's still the company packaging and the company is liable, but they can make counterfeits that look it just creates a whole bunch of nightmares. Tax credits, if you donate a certain amount of medicine, you get a tax credit. Similarly, you can write off something on your books, which again financially may make a lot of sense to say, I donated X million dollars worth of drugs, and you get a write-off. So you get financial incentive. You establish a reputation. Again, as I said, today in the world that we live in for pharmaceuticals, and biotech companies, it's really essential to have that reputation of being a good company to work for, a good company to partner with, and create goodwill. By the way, goodwill is actually measured in dollar terms. So on a balance sheet, you will see that a company has a certain monetary value to goodwill. When I say Johnson & Johnson, what comes to mind? Babies.
Text for baby.
I'm sorry?
Oh, I was thinking text for babies.
Okay, yeah. So it's Johnson & Johnson is like the family-oriented. I mean, they're one of the largest drug companies in the world, and they will never take on something that jeopardizes their image. Even if it could make them $1 billion, they would never take that on because it jeopardizes their image. Similarly, companies will spend money so that they can put on their websites and they can put posters on their walls saying that we have cured 10,000 people in Rwanda or Ethiopia or India, or because it makes them look good. And if they look good, it not only creates goodwill for their company, it also establishes their reputation, which is very important today. To become, again, to put your house in order, a partner of choice allows you to be the person that those people in a garage who have very interesting technology come to, because they usually have more altruist, they're usually more kind of, we want to sell this to the people who will take this technology and do something really good with it. And you go to the people who are doing good. So kind of good begets good. And you also increase the breadth of your portfolio. So if you go after these orphan drug status diseases, then you actually expand, get away a little bit from cancer or CV, and you might end up with a market that is unexplained or unanticipated. The last part is really my experience, and I began this by telling you about the Privosec Nexium example. I was one of the people in that room, and I was one of the people who, one of the many people who worked on that strategy of making Nexium and spending, company spent over $500 million in 6 months to market that drug. And I remember we did all this in a secret basement location in New Jersey, and I remember we had worked for I think 8 or 9 days straight. I mean, literally, we would go out in the afternoon to get clothes because there was no time to go home, so we would just go. It was madness. And I remember at 3 o'clock in the morning, I drove to Newark Airport to go to FedEx because the last pickup had already left, and I drove there to hand the press release because it had to be signed, and it was all signed and couldn't be done over the internet. And I just remember thinking, this cannot be it. Like, this is. I mean, I just finished. I've been through an MD PhD program. I had an MBA. I always wanted to do something good rather than sell more soap or sell more Lipitor or sell. I think this cannot be it. Like, this cannot be the purpose. And one of the good things about the consulting company that I worked for was that we did have a exceedingly large nonprofit practice. So we, since we were very good and very successful at what we did for money, we were able to take a chunk of that and actually do things for nonprofit reasons, just to help governments, to get help health initiatives, to help a number of things. And one of the things that it was a study at that time, which I was very fortunate to be involved in, was the ACHAP initiative. So just a little bit of background. The Merck & Company is a foundation, and it's actually a very socially responsible foundation. And Merck initially decided to have this consortium with the Bill and Melinda Gates Foundation to provide HIV treatment protocols and prevention programs in Botswana. The reason that they chose Botswana was because the country actually has a good infrastructure. It's a relatively well-established government, political stability, good literacy rates, etc. But unfortunately, it also had one of the the second highest HIV prevalence in the region. So initially, there was the CEO of Merck was a good buddy with the director one of the directors at McKinsey, and they had a lot of issues because the person that they sent from the Merck Foundation could not get along with any of the people on the ground in Botswana, because Botswana has what is called a consultation mentality. So you go in and you talk about things, and you go away, and while in a business model, the person that you talk to kind of, you understand, okay, I need you to do this, this, and this, and the next time we meet, we will have these deliverables, versus it was a matter of we meet again 5 times, we talk about it, and there was never any end point, and the executive that was sent was frustrated. So they actually asked us to step in, McKinsey & Company to step in and actually run this pilot program and run this initiative. And the person who, so there were 2 directors who were helping us, and then there was this amazing, one of the most amazing people that I've known, Ernest Darko, who was from Ghana. He then studied at Harvard Med School and went to business school and worked for McKinsey. And they set this team up, and we went in to Botswana, to Gabs. We went into different rural areas, and we actually did a feasibility study on what a comprehensive partnership would look like. So we did it in a really kind of a business sense. So we treated it as what would be the measures of success? How would we account for blips in the way? Who would have ownership of what? So it's kind of a very this is kind of the way that we thought about it: policy setting, grant application, budgeting, monitoring, coordinating, and executing. So there was a part that was just the strategy, and then there was the part that actually was the execution. And this comes from 2 years later, we did another study just to assess the effect of public health partnerships and public-private partnerships in Africa. And this is what we were told is, even in these big pockets of grant applications and budgeting and coordination, people wanted help. And these public-private partnerships are not working because the public sectors were actually not able to articulate what they needed. And I'll give you a very simple example. Grant applications. Most people in the public sector, most people in government don't know how to write grants. or miss out on attaching an appendix, or just make a very simple error. And for that reason, your entire application, it's like submitting an R01 and not putting, the number of references or, the needed. And it's just a kind of, I don't know exactly what happens there, but, in these cases when you have, so many grants and only a certain amount of money, you can actually not get funds because you just missed out on 2 sheets of paper. And people just were frustrated in government because they didn't get to that minute point of detail. And they said, we need help doing this. Like, countries were actually losing billions of dollars because they had not properly filed a grant application. Money was there. The private sector wanted to give it, but the public sector didn't know how to get it. And we heard that over and over again. And, just misalignment, confusion, who owns this, just, a number of things. So, we learned several things doing this partnership, and we said, okay, what does the public sector bring in? The public sector basically brings in some kind of methodical, business-related, application. So it's like, what do you start with? What do you want to do, and what do you end with? So very measurable. What is the focus? Is it on a disease? Is it on a country? How many people do you want to serve? How will success be measured? Will it be measured on how many people you treat? Will you measure it on incidents? How will you measure success at the end? For the public sector, we really felt strongly that they're the people who need to articulate the need. So they are the people who need to own it because they are the people who live there. So it is in their backyard. Us coming in for 4 days out of 2 weeks, and then saying nothing happens because of that. Until someone has ownership, it doesn't move forward. And also infrastructure was huge. I remember we had the money to bring in these when we went to Botswana, we just found that one of the biggest issues was that there was not enough infrastructure. There were no pharmacists, there were hardly any pharmacists, there were hardly any physicians, there were hardly any nurses. We needed to bring all these people together. So we brought the people together, but then there was no place for them to work because the pre-manufactured units that we had actually bought and no one knew how to put them into the ground. So they were just sitting there. So it's just these logistical issues, and until someone on the ground, we couldn't bring in a carpenter. That would just be insane. And so you figure that someone on the ground needs to take ownership of this and really, push it through. And unfortunately, that doesn't really happen. If it does happen, and if you do get this happy medium, I think, partnerships in public health can be really meaningful and create sustainable change. They can be long-lasting, they can create goodwill. Examples of this is certainly the Gates Foundation. What they're doing with malaria, and it's phenomenal. Again, because they have, if you see the kinds of people that the Gates Foundation has hired, and they actually hired a lot of people from the team that I worked for to run their different initiatives, they are people who are from those countries. Ashok Alexander runs malaria for the Bill Gates Foundation in India. He was one of my team leaders. He is from there. He knows the language, he knows the people, he knows how to get around things. He knows the bureaucracy, he knows the corruption. And so again, if you want meaningful change, you have to get people who are personally involved in it rather than come in, for a certain amount of time and then leave, because things just don't get done that way. And it's always a learning opportunity. So it doesn't matter what disease you're going into or what country you're going into, it's always a learning opportunity to say, what did we do best? What can we do better next time? And I'll just leave you with this. Strategic partnerships should create value for each partner. Again, we've talked about the corporate responsibility for private companies, the good for public health, and if you put them together, in this case, as the Merck Foundation, Bill Gates, and then government of Botswana, and then ACHAP, you actually see that ACHAP didn't just support this one thing; it actually globalized a commitment. And today, ACHAP actually provides free treatment. The treatment is free, still funded by Gates and Merck and others. And they're one of the more successful programs in this field. So I'll be happy to take questions. Yes.
Can you go back to the previous slide?
Yes.
So in this slide here, it sounds like what you're saying is that what the private sector is getting out of this is corporate social responsibility and good PR. Is there any way that this can work such that the private sector can make money out of it so that they're motivated to stay in this kind of partnership over the long term?
Yes. I'll answer that in two ways. So the one thing that you said is, yes, the social responsibility, it creates goodwill, and goodwill creates a nice chunk of change on your bank, on your end statements. So yes, the goodwill does pay off because you can monetize that, and it actually does pay off. The second thing is, remember, as I said, you want to be the partner of choice today, especially when your pipeline is dry and you have a young startup company that has very promising technologies. You want them to come to you to say, can you take my product through? Can you co-market this with me? Can you take this through? You want to be the partner of choice. And the way that you are the partner of choice is that you're top of mind for people by doing these kind of meaningful relationships. So when you do these kind of relationships, one of the outputs that is necessary to keep these relationships going is recognition. So if for example, if Roche provides, ARV treatments to a certain country, they will certainly put that in the press. There will be a way that people will get to know about it, right? And that's their quid for putting in the money and the resources, and that's their quid. Now, as a result of that PR, as a result of the goodwill that they get, they may very well be the partner of choice for some company that's developing an oncology drug. And that company comes to them and says, can you take this forward? And they can work out a deal, and then they kind of have received goodwill and a benefit that was completely unrelated to, but because of this partnership.
So then are those benefits from goodwill, do they tend to happen more in Western countries where these companies are based, or do they happen also in low-income countries?
They happen exclusively in Western countries because all of drug research, biotech research, 98% of that research happens in the United States, which is also the reason that they will argue that prices are so high because they have to fund that research. And so it is true that the West or the United States bears the burden of the cost of the research, and hence, should be expected to recoup the benefits.
So you ended with that this was a very successful public-private partnership deal. But how do you measure success in these kinds of cases? I mean, I can understand maybe you no longer have the snags of the Ministry of Health not knowing how to submit a grant. Do you measure it in terms of the amount of grants they get in, or successful applications, or actually in reduction in disease burden, for example?
So we laid out very specific goals over specific times. So we actually had a Gantt chart, and we said that in 15 months we wanted to treat, I think it was 29,000 people. And we had this very nice chart that we said, okay, if in 15 months we get these many people under treatment, then we will be successful. Unfortunately, as life is, it never worked out that way, because actually we grossly underestimated how sick so many people were. So we had to completely change, and we actually had these how in the grocery store you have an express line and you have a regular line. We actually had to do that for very sick people. They were in another line and then we had to give them different days and times so that so that no one was coming there and not getting the treatment. Because what happens is the people who are sickest get the most treatment, and then you neglect the people who are not that sick, and then they kind of fall into that vicious spiral. We also did at that time the norm was opt-in, which was basically saying that if you came in, you were asked, if you came into a clinic, you were asked, do you want an HIV test done? So we changed that model and we did an opt-out. So we did it unless we were expressly told not to do it. Now in the United States, that would come with a completely different, ton of ethical issues, etc. But we had very specific goals of, success would be these many number of people treated, these many number of cases, etc. I will be very honest with you and tell you that it actually never worked out that way, because we did it as, people talk about academics, but in an ivory tower, and when you're on the ground, there's no way to anticipate those things. The reason I say it's successful is because I think that both partners, the public, which is the government, and the people, and the private, foundations, as well as the companies, many other companies who have donated since then, are still active, money is still going in, and for whatever measure they're using now, it is still a program that is on the ground, helping people maybe not as many people as we had anticipated, but still running, versus having dissolved and kind of gone to the wayside a long time ago.
Sustainable.
Yes, that's all. Yeah, if it's not sustainable, it's not possible.
Most things aren't.
Yeah.
I also like your approach, like educating instead of medicating in public health. When you were talking about the pharmaceutical industry, I'm also teaching the class like drug abuse and its prevention. So we go not just on the illegal drugs, but also the prescription medications. So I was quite familiar with what you were explaining, and I always explain students like they see the Lunesta, the beautiful, not butterfly, the moths actually, island, and showing like people are so happy, you know, in the morning, but then you have, you know, written additional things. This is probably for 2 weeks, and you can be addicted, and all the side effects. And I know that many times students ask me, okay, so what can we do about it? How we can, you know, go ahead with more educating? Because I mean, this is important information the public should know about it. And I'm sure that if this will be, you know, explained to the students, I mean, even they are in public health, they will know. So what we can do with this message and everything, I know it's like future, but any, you know, suggestions?
Yeah, you know, one of the things that I tell my students, and it's very effective, is, you know, most people think that because the drug is on the market and it's approved by the FDA, it is safe. Like, I think there's this image of, oh, if it's FDA approved, then it must be safe. And I show this documentary, and I cannot remember, it's a PBS frontline documentary to my students, and it actually tells you about how the FDA is funded by the drug companies. And so, you know, the whole dynamic of the people who are supposed to be looking out for creating a, you know, not a totally safe, but a, you know, a safe, effective drug, it's kind of gone, you know, on its head, because the people who are supposed to be watching out are not watching out. And I also tell them, you know, I'd ask you, how many of you take probably medications, and how many of you know what the NNT of your medication is? You don't, because, you know, how many times is that made public? I mean, I think more people are getting, you know, aware of these things, but it's still kind of hidden away, because what, like you said, what you see the pretty ads, you see the people being happy, you know, and all that kind of stuff, and it's not something that the companies want to have come out. But, you know, it's something that definitely, you know, in today's age, you know, like when you can have a Facebook account and you can click like for Lunesta, and then is that advertising? Like, you know, do you just advertise that to your whole friends list? And you know what, like I slept really well last night because I had Lunesta, and then, you know, and then someone takes it and they have a side effect. Did you just actually advertise it to them? You know, so it raises a whole bunch of issues. So I don't have an answer for you, but it's just, you know, more information is always a good thing.
I think it was 2 months ago, there were news headlines about fraud in global health. It was something, I think the tropical diseases funding program that somebody did an audit, and something like, I don't know, 60% of all the drugs were stolen. Was the word that was used, and I don't know what, and so there's a lot of hand wringing about the credibility of all of these multinational healthcare groups and the donation they receive, and that it's not really going to you know, the right people, apparently. It's gone past the headline news, but I don't know if there was ever anyone held responsible. What do we do differently? How do you regain credibility? They're big questions, and I don't expect that you have an answer.
Yeah, no, that is certainly something that we had looked at, and again, that's why I stress that, you know, it's the public sector, it's the people on the ground. If they don't have the ownership and the, I don't know how to call it, but the real deep desire to do something, to move forward, to do something, it's not going to, I mean, I'll give you another example is, you know, not HIV, but for respiratory diseases, you know, antibiotics, you know, things that are applicable for other diseases as well. So, you know, those are the drugs that are actually, you know, very hot items on the black market, because you can actually use those for other, you can actually sell those for other diseases. And, you know, I've seen people exchange, honestly, like a bottle of Coke for, you know, Coke, like Coke, not cocaine, Coke, for, you know, a strip of pills. I mean, I've seen it. I have seen it with my own eyes. It happens. And what do? Like, you know, I mean, you think, well, someone somewhere needs this, obviously, and so if they're taking this and using it, then my thought is, as a naive, bystander, is at least someone's getting some good use out of it. It's not going for the use that it was meant to, but it is the other. But I think the bigger issue is the arbitrage, right? Because if you think of all these drugs that go there out of a partnership like this, and then somehow they find their way back into the United States, that is not a good thing, because first of all, we don't know kind of the conditions that they were stored in or transported in. They come back and then they're sold on the black market, and there's arbitrage. So basically, there's an opportunity for someone to make a profit because they're actually given for free. So I think that that is definitely top of mind for these kind of partnerships on how to, not.
Well, yeah.
Oh, just one more question. I'm wondering how receptive executive MBA students are to this, and this might be the reason why you're actually applying for this job. I don't know if this, because I would imagine a lot would not be terribly open.
I've never. I mean, this is not this.
This isn't stuff that would ever be interesting.
No. I teach in the executive MBA program. I teach current issue. I teach more kind of current topics in healthcare. So kind of more what's in the, like you said, what's in the Wall Street Journal, what's in New York Times, etc. Things like that. I do teach a class, an undergraduate class called The Business of Medicine, in which I do go over some of the things that you mentioned about what is medicine. I mean, is a business a business a business? Because a business needs to make profit, but should the business of medicine actually be that, or should there be another element? But no, no. I'm sure there would be. I'm sure there'd be a lot of Z's in there. Yeah, no.
On that note, let's go to lunch. Yeah.